Good afternoon, everybody. Welcome to our session on the National Back Pain Clinical Network Implementation and Knowledge Mobilisation session. Hopefully we're going to have a really good session today. We're going to be focusing on the implementation of the pathways, but it should hopefully be relevant for all implementing evidence into practice, whatever role that you work in. First up, we're going to have a presentation by Phil Ackerman, who's a consultant physiotherapist at NHS Lothian, and he has been involved in the implementation of the National Back Pain and Radicular Pain Pathway. And then this will be followed by a presentation by Dr. Kay Stevenson, consultant physiotherapist and honorary professor at Keele University and a senior knowledge mobilisation fellow. And then following that, hopefully we'll have plenty of time to take your questions. So please do start putting them in the chat box. And myself and James Greenwood are there, hopefully moderating and getting the questions to the speakers. So thank you very much. And we'll start with Phil's presentation.
Hello and welcome to this presentation. My name is Phil Ackerman. I'm a consultant musculoskeletal physiotherapist and work in NHS Lothian in Scotland. And today I'm going to share our experiences of designing and implementing a whole system back pain pathway in a health board in Scotland, namely NHS Lothian. I'm going to try and demonstrate the commonalities and differences in integration of the National Back Pain Pathway into our work and share our experience and learning. First, I'd like to start by thanking the organising committee, especially Susie McElroy and Jim Greenwood, for the very kind invite to come along and present at BritSpine. I'm really very humbled to be asked, and while I'm here presenting today, the work I'm going to share is a result really of a huge effort by a large number of people. So let's start with a bit of geography and background. Well, Scotland has a population of just under 5.5 million, and within Scotland, health is a devolved matter and as such rests with the Scottish Government. Scotland is divided into 14 regional health boards with 7 special NHS boards. And in contrast to NHS England, there is no purchase provider split and no internal market. In Scotland, all healthcare staff except for GPs are employed by the health board, and most GPs are independent contractors. However, some are also employed by the health board. NHS Lothian is the second largest health board in Scotland, and it serves a population of just under 900,000 people. It employs 26,000 staff with an annual budget of 1.6 billion. It's divided into an acute division, which manages hospital services, and 4 health and social care partnerships, which provide integrated primary and community-based health and social care services. Let's now look at setting the scene around back pain in Lothian and Scotland. Well, based on the Versus Arthritis calculator, it's estimated that 172,000 adults within the Lothians live with back pain each year. And within the 2016 Burden of Disease study in Scotland, low back and neck pain is identified as the leading cause of disability and also the problem with the second highest overall burden of disease. Now focus on the background behind the development of the back pain approach in Lothian. And the story really begins in 2011 with a large national review of spinal services in Scotland. And it was this paper which really set the direction for the need for redesign of services for people with spinal problems. It identified a number of care quality issues for people with spinal problems, some of which are listed here. And I believe these are common to those identified in the diagnostic work undertaken by NHS England, leading to the development of the National Low Back Pain Pathway. So in response to this work and a number of other drivers I'm going to touch on in a few moments, an MSK Pathways Programme Board was established to begin to address these quality issues. And within the board, all specialties represented who inputted care to people with spinal problems. The board's purpose was to provide the oversight and accountability for the work to redesign MSK pathways, with the back pain pathway being the first to take forwards. The board was underpinned by shared values, those of NHS Lothian and Scotland, namely care and compassion, teamwork, openness, honesty and responsibility, dignity and respect, and quality. And the board also established a shared vision based on the underlying principle of right care, right time, right place. This time there was also a number of key other important drivers and developments which we incorporated into Pathways design. First, the realistic medicine, which identified 6 core principles which were being developed and championed in healthcare at the time, including a personalised approach, shared decision-making, tackling unwarranted variation, managing risk and reducing harm and waste. There was also development of the What Matters to You question being incorporated into practice, and within the allied health professionals, there was the launch of the minimum standards for musculoskeletal pathways, and also the Making Every Contact Counts approach, including conversations around smoking and physical activity with each patient. Finally, the Scottish Government had also launched the Quality Drive around MSK, orthopaedics and neurosurgery, and this further drove pathway redesign. Around this time, NHS Lothian had also chosen to tackle the long-term challenges of rising demand, costs and limited resources by making quality the focus of how it runs its service. It developed its quality management model based on Turin's trilogy system, the key ethos of this being a focus on working together with co-design, co-production of work strands, focusing on the patient at the centre and developing an integrated whole system structure. And this approach and culture really helped forge the pathways for the programme board and drive this work forwards. So the approach that was taken in simple terms was really to decide, well, who was the right person in the right place at the right time to manage the various presentations of people with spinal problems. And in that way, time-dependent pathways developed for those presentations which required urgent, emergency or routine care. Pathways were also developed in the concept of case complexity, where the highest volume, lowest complex cases were managed in primary care, increasing complex cases through adult MSK outpatient physiotherapy services, higher complex still through spinal advanced practice cases, requiring diagnostic workup and so on, and onwards to neurosurgical services for cases which required surgical opinion, so radicular pain with concordant surgical target, or highly complex cases and serious spinal pathologies. Importantly, there was common triage criteria agreed and shared across all specialties, and in this way, any misdirected referrals would be passed to the most appropriate service and level within the service and system. When the national back pain pathway was developed thereafter, the detail was reviewed to ensure a consistency of approach. The pathway was launched under the title of the Integrated Back Pain Pathway and Service. And I'm now going to highlight some of the key elements of the pathway and service before we go on to summarise some of the key outcomes and learning today. So this slide serves to summarise the various elements of the services to support the individual with their spinal complaint. And these services are the ones integrated under the back pain pathway and integrated back pain service. These annotations show the flow between the various levels within the service based on that concept of right care, right time, right place. So starting at the centre with the individual, well, a package was developed as part of the pathway and services to support the individual with their spinal problem. This tried to ensure a consistent message and approach. There was a variety of material, including video, leaflets, posters and patient guides produced. And this also linked with the NHS Inform, which is Scotland's National Health Information Service. Moving out with primary care, there was a package of resources built for primary care clinicians designed to support that primary care clinician with regards to decision-making and referral. Within the resources was an interactive web-based pathway and decision-making tool, which was developed in software produced by the NHS Education for Scotland. And this is similar really in terms of the package of capabilities developed by the National Back Pain Pathway Programme and once more incorporated into the design of the system and the service. Other resources included signposting of patient information, focused education and targeted improvement in projects and training based on data from the service and the pathway. Moving out to the extended primary care and community care MSK services. Within Lothian and NHS Scotland, care at this level is provided by adult MSK physiotherapy services. Once more, a package was developed to support these clinicians, specific interactive decision-making tools, triage criteria, focused education and training. Startback had already been embedded into MSK physiotherapist services, and its use continued to stratify patients. Prior to the back pain pathway launching, there'd also been a large-scale programme of work to upskill the musculoskeletal physiotherapy workforce in Lothian and the management of people with chronic pain. And this work developed clinicians to minimum standard pain training with a smaller cohort of level 3 trained physios in each health and social care partnership across Lothian. And these clinicians are the ones who are highly specialist in the biopsychosocial pain management approach. They'd undergone extensive training in partnership with pain management services, including psychology, and undergone periods of mentoring with psychologists. And in this way, they were able to provide forms of group combined physical and psychological treatment programs. These clinicians also had strong links with pain management services and their pain management programs, and patients are able to be referred accordingly for higher level input as required. This work was incorporated in the integrated back pain service and pathway. One of the other new developments in the pathway was those of the integrated MSK service. And this formed the interface between primary and community care and secondary care. New spinal advanced practice physiotherapists were employed, and these are highly experienced specialist physiotherapists akin to the specialist spinal triage practitioners of the National Back Pain Pathway. Importantly, they sit and deliver clinics both in primary and community care alongside musculoskeletal physiotherapy, but also within the acute hospital and neurosurgical setting. We undertook a large programme of work developing these clinicians, their skill sets and capabilities and scope, including the ability to arrange and interpret investigations. And a key important element of their role to work closely with consultant neurosurgeons, undertaking weekly virtual clinics to discuss cases and seek opinions. And in this way, care is coordinated across surgical and non-surgical services. And here are the key secondary services involved with the integrated back pain service and pathway. And as described over the last couple of slides, the key importance is that they are integrated with musculoskeletal physiotherapy, the spinal APPs and primary care services. So moving on then from the design, implementation and key aspects of service and pathway brings us to the important element of evaluation and data. Really, given the whole system approach of the pathway, there's required to be evaluation of multiple elements across the services to understand the processes and impact of the work strand. I've simply tried to highlight a few in this slide. It's certainly not exhaustive. Consistent with quality improvement methodology, data is evaluated continually and utilised to develop focused quality improvement projects through the system. And annual reports also provide summary of the key aspects. And once more, I've just put some simple examples from the data. So this slide serves to illustrate a typical year. This is the year of 2019. 2020 is currently under analysis and will be launched soon. So of those 172,000 people who we believe live with back pain in Lothian over a given year, we feel around 36,000 will contact their GP over a given year to consult. Of those, just under 13,000 are referred to routine MSK physiotherapy clinics across Lothian. From here, around 2,000 are seen within advanced practice spinal clinics. From there, 500 cases are discussed at virtual clinic, and typically around 170 cases referred onwards for neurosurgical opinion. And this is fairly consistent now over the last 5 years. This has therefore meant that around 10,000 patients over the last 5 years have been shifted back out from neurosurgical services into primary community care services. This has had a marked impact on secondary care weights and neurosurgical conversion rates, and certainly shifted that balance of care. So in terms of trying to move towards summary, I thought it'd be helpful just to think about some of the key elements of the design and programme. I felt that the key successes are based on a collaborative, co-created whole system approach with shared vision, shared cultural values, shared behavioural values, really embodying those realistic medicine approaches and what matters approach. The monitoring of the project, the implementation and accountability through the programme board was paramount, as was a data-driven and quality improvement methodology approach. This allowed targeted, focused and continual improvement projects to be undertaken, and the services really tried to be responsive and adaptable to a changing landscape, integrating evidence-based approaches and new developments. So now in the future, well, we're certainly facing significant long-term challenges around ageing population, increasing complexity with comorbidities, demand, resource and finance. We're facing challenges around public expectation with imaging, despite all the work that we undertake around myth busting with this. There's challenges around DCAQ, so demand capacity and queue within services. Outpatient Services Redesign Programme will hopefully go some way to supporting some of this work and some of these challenges through integrating remote consultation and some of the work that we've undertaken through COVID. Asynchronous digital appointments will be potential for development, as will digital delivery of pain management programmes and other combined programmes. We're now in the process of moving from low back pain to our integrated whole spine service, and this is undertaken in pilot. We're trying to embed outcome measures within the service at all levels and continue that targeted improvement approach through a data-driven strategy. So hopefully that gives an overview of our journey of developing and implementing the back pain approach within Lothian. Thank you very much for listening.
Thank you very much for that brilliant presentation, Phil. I'm really sorry that we lost the slides for a while there. Hopefully you could still hear. We will now go on to the next presentation by Kay Stevenson. Please do start putting your questions in the chat so that we can address these following the presentation. Thank you.
Hello, everybody, and good afternoon. It's a real pleasure and an honour to be asked to talk to you this afternoon at your BritSpine conference, and I hope you're all enjoying the conference so far. So my name's Kay Stevenson. I'm an honorary professor at the Impact Accelerator Unit at Keele University and a consultant physiotherapist. And I'm really delighted to be with you here this afternoon to talk a little bit about knowledge mobilisation and how that might help us in thinking about methods or mechanisms we might use to help change our practice. So the aims of the session really are to try and introduce us to the concept of knowledge mobilisation. What does it actually mean? I'm going to share with you 3 methods that I've used recently and highlight some of the benefits, but also some of the challenges along the way that you might want to think about, and share some of those top tips with you as we go through those experiences. So a little bit of a background. I don't really need to tell you all in this audience that we know that globally that many millions of people don't receive evidence-based healthcare. They don't receive healthcare that is based on guidelines or on the best available research evidence. And this is known as the research to practice gap. And if we look at the literature, there are many reasons why this exists, and that might range from having the lack of skills to be involved in looking at the quality of the literature, lack of awareness of the literature, lack of access, or even a cultural setting of not being used to looking at the evidence and utilising that to base your clinical practice upon. But we do know for sure from the literature that it is a very complex process. And if we look to the sort of historical transition of some of the terminology that's used around this concept, we've moved from research utilisation, which made us think a little bit about that this was a very linear process. As long as we produced the research or the knowledge, then it would automatically be taken up in practice. But we know that this is a much sort of an oversimplified view, and that then we moved to evidence-based practice. David Sackett, father of evidence-based medicine, helped us to think a little bit of this triad of patient experience, the evidence, and our clinical expertise as being important. And then we moved through knowledge translation to the first emergence of knowledge mobilisation seen in the literature in about 2008. And knowledge mobilisation, well, what does this mean? Well, I want you to get the sense that it's much more of gives us an idea that it's rather than a linear process. it involves much more of a proactive approach to taking evidence and research and knowledge to where it's needed. So a couple of definitions here help us to think about that it's not linear, that there is something about this social interaction that's really important, but we need to be doing something more proactively in terms of taking the research to where it's needed. And these two definitions also help us to think a little bit about that more action is required, more effort is required to taking the knowledge to where it's most needed. And this definition here tells us it's not sufficient to produce the evidence. It's also about understanding those processes and the actual place in which that knowledge and research might be used. So it's much more than producing the research, it's having a knowledge of where it's going to land and in what landscape and in what context. And I hope this illustration helps to get this in your minds, that it's not enough to create the knowledge, we have to move it, actively do something with it to move it to where it's going to be used. So here this guy sitting on the light bulb, which is the knowledge, is actively driving it to where that knowledge is going to be yet best utilized and best served in terms of use in clinical practice. Well, out there in the literature, there's over 60 models to help us. So a very sort of literature, very rich in its literature, but there are some things that we need to be mindful of here, that culture, trust in trying to bring knowledge mobilization to the fore is really important. If we're going to do it properly, the power relationships and trying to create an understanding of power dynamics is important. And also creating a language that people can understand. Bringing stakeholders together is really, really important, as we've seen from a lot of work around improving pathways for low back pain. Relationships are key, but this idea of doing things together and co-creation. And we're doing this because we know that knowledge is kept in silos, and there really does seem to be a bit of a disconnect between what the researcher understands and what the end user of that research needs to have to help them embed it in their practice. So some things to help us kind of take our thoughts forward, really. So I'm going to talk to you about 3 examples that I've used around knowledge mobilization that I found to be really helpful. And the first one is around critically appraised topic groups. This is where we brought together for over 10 years now groups of clinicians, researchers, librarians, patients to actually look for the best evidence around questions that come from clinical practice. So rapid change is possible, it's based on the best evidence, and it supports groups of individuals developing skills in understanding the literature. And it also generates this inquiring culture and fosters that and nurtures it, because it really is a co-owned process. It can help you identify gaps in the literature, but it creates this mutual understanding, and it does very much feel like a shared endeavour. I would say my top tips here are around a consistent leadership is important, and the relationships between the clinical lead, the librarian, and the researcher in this group is really, really important. And it's important to have those 3 people in place to maximise the impact of these critically appraised topic groups. I've put the link there to our web page where you can find out much more information about this type of work if you would like to. My second suggestion for you is utilising a community of practice. Now, a community of practice really brings together people who have a shared interest over a period of time to co-create solutions based on their shared understanding of a problem. So the management of low back pain might be one. And doing this together, you really understand each other's perspectives. You all start to understand the barriers from each other's perspectives, and it encourages this co-creation of meaningful solutions. Getting patients engaged in this can be very powerful and liberating and make patients feel valued. I've used this in a couple of big projects, one around trying to embed the evidence from moving forwards, the NIHR themed review in our practices around Staffordshire. and also in some work around embedding some changes around linking mental health and physical health services together. I would say to you that evaluation of this is important. Keep evaluating your impact. Sometimes sensitive leadership is required. Certainly I learned from my work with patients with mental health related issues that my normal kind of musculoskeletal outpatient way of working, which was pacey and quick, didn't quite fit that context. And so you have to be flexible. And both clinicians and patients may need your support in terms of getting the best of this methodology. Finally, I've called these the final method exploratory methods, and I've called it people power, really. So trying to get new people, new posts, new people having the conversations about changing practice. So I'm going to introduce you to two people here, Mr. Mike Brooks, who's our first patient that we've employed in our musculoskeletal service. He's got a temporary contract for 6 months, and he's really creating ripples and waves already, asking us why and how we're doing certain things. And this has really brought the patient voice absolutely into our service redesign. And we're going to introduce to Dr. Johnny Quick, who's an activity coordinator. So he's responsible for talking to communities, not into the hospital, but into communities. And so these two examples of patient and people power mean that we're having different conversations with new people. And so I found these really exciting posts in terms of having new conversations. So they're community facing, they're different in terms of different people communicating our message. So here my top tips are about being brave, exploring opportunities for these types of roles. We've had to be persistent in developing them. They have taken some time to develop, but always be prepared to listen and support these new roles as they embed themselves. So I'm hoping those three methods have given you some ideas of how we might try to bridge that research to practice gap by engaging patients, engaging the public, engaging clinicians in trying to co-create solutions to our problems together. My advice to you would be, my top tips really to finish with are always play to your strengths and work with the willing. So collaborate and involve everybody. Share your successes and your challenges because they're equally important in terms of the learning as you go forwards. As leaders, try to create new opportunities and aspirational opportunities, but seek out those different voices and different opinions. It will only strengthen your understanding of the different perspectives. And also do a lot of reflection on your own style, because your own style, you might have to be flexible and be adaptive. Create a language that everybody can contribute to and everybody understands, listen and lead. So I wish you loads of luck with any endeavour that you're going to take forward. I'm very happy to chat to you outside of this meeting. So enjoy the rest of the conference and we'll be around for some questions at the end of this session. Thanks very much. I've included my email and my Twitter handle there, so please be in touch if I can help in any way.
All right, thank you very much, Kay, for inspiring talk there. Unfortunately, Kay is having some audio video problems and can't get logged in at the moment. She has been looking at the messages in the chat, so she will try to respond to those. So Phil, looks like a few of the questions will be heading your way. And to start with, there were a couple of questions. One from Christine Comer. She was interested in how you got your the biopsychological training funded for the physios, and on the back of that, I'm quite interested to what training did you arrange for them?
Yeah, thanks. Hi, Christine. Nice to hear from you. Thanks, Susie. So yes, it was rather fortuitous, to be honest, in that we had a very sort of enthusiastic physiotherapist who was really keen on chronic pain management and had really done a sort of large program of work around upskilling physiotherapists in this area. And that had been undertaken prior to us launching the back pain pathway. So it was really sort of a fortuitous development that we were able to sort of join up with the pathway work. In terms of the background, as I sort of alluded to in the presentation there, we have different levels, if you like, of pain training. So level 1 is where physiotherapists come in with their basic understanding. Level 2, they're upskilled to a certain degree, and level 3 is really where they have that much more complex understanding by psychosocial approach, and they've had mentoring and input from the psychology team and the pain management team, and that's where the link between the specialist secondary care pain management services and musculoskeletal physiotherapist services have joined up. Christine mentioned about funding. I suppose it's quite a different sort of funding structure in Scotland. Everyone's funded by the health board, so we all have the same employer. So what we're able to do is really just sort of work collaboratively between services. And obviously it was time well spent for pain management services and psychology to input to MSK physiotherapy, with the idea that if you upskilled a resource in the community, that would obviously therefore have an impact and potential reduction in demand on a specialist secondary care service. And in that way, it's about shifting the balance of care, providing care close to patients' home. Also, of all those agendas were taken forward.
Great, thank you. Jim, do you have another question?
Yeah, hi Phil, thanks. Sorry, you're going to bear the brunt of this because Kay's having technical issues. Dermot asked a question about what are the key areas to focus on to achieve key wins, and thinking about what Kay has just said, did you have expert patient involvement? Because that seemed like a very appealing element to her model.
Yeah, thanks, Jim. So within the MSK programme board, we did have a patient representative, along with a representative from all the different specialties who had involvement in back care provision. So yes, there was patient involvement. What were the sort of key things, as Dermot was asking? Really, for me, it is that sort of whole system collaborative approach between all the disciplines. So getting the sort of enthusiastic people who are really keen to drive this forward. So, we had an excellent team of consultant neurosurgeons who were really enthusiastic to take this work forwards. And in that way, they were very, very supportive of the physiotherapy teams. They put a lot of time and investment into upskilling and training the spinal advanced practice physiotherapists. We have a sort of collaborative approach within the MSK physiotherapy teams to try and share sort of best practice. So I suppose ultimately it's trying to get those people who are really enthusiastic around the table who wish to sort of drive this all forwards, and making sure that it is truly collaborative and that it's not really a sort of silo-driven single service approach. And I think, to be honest, that sort of benefit we have is that everyone's employed by the same health board. We all have the same employer. We all work to the same sort of values, if you like, and have that sort of team ethos and vision that we're able to take it forward.
Thanks, Phil. Very good. Susie?
Yeah, there's been quite a few questions coming in for Kay. I do apologise she's not here. She has put her email address in the chat, so anyone that wants to contact her, please do. Also, Louise has asked where could she find out some more information about the examples of the knowledge mobilisation. Again, I'm just trying to get that link because Kay did give us a link on the presentation that I'll try to put in the chat. Also, if you refer back to the on-demand service, which will be available either tomorrow or very soon, and go back to her slide, I'm pretty sure there was a link there. So it's now 5 o'clock. So unfortunately, we have to draw this session to an end. I do apologise about some of the technical issues. If you do have any other questions and want to put them within the networking lounge, we will try and make sure we can answer those for you. So thank you very much for all your participation, and thank you very much to Phil, Kay and Jim.